Well, good evening. For everybody that's online here, we are really in store for a very good presentation by Dr. Bill White, who is going to teach us what it is to have medical challenges at sea and perhaps how to deal with them. Um, our next slide shows the individuals who are. Uh, I'm Tony Tomasello. I'm your president. And Davis Jones is our vice president. We have an assistant vice president, Greg Pabst. Bob Thompson is our secretary, and Carl Bart is our treasurer, who's been our treasurer for quite a while, and he's doing a fantastic job. And of course, our communication person is Mike Clark. Continuing ed now is Mike Dillon. Laura Olson, job program. Phil Gaither, membership. And of course, Cheryl Duvall is doing a phenomenal job getting programs put together for our group and for the public. Dave Sire is our webmaster, and again, everybody's doing such a great job. Hillary Howe, Alan Karpus, and Rob Doolittle are our members at large. I want to welcome the new members. In May, Kevin Scott and Kim Gravitt have joined CAPCA. These are our new members since December, and we now have total members of 333. We were at the boat shows and telling the other people at the displays, when they have boats that are sold and need deliveries, get in touch with CAPCA, because we've got 333 captains who can do those deliveries. And so I'm very proud of the organization growing and taking the opportunity to look at those job posts and pick up opportunities to use your license to make money. I won't tell that story here, but I'm going to turn this over now to Dave Aller, who is going to be introducing the programs and introducing the speaker. Dave, it's all yours.
I appreciate it. Thank you, Tony. So speaking of making money, there are people with their license actually making money, and our discussion next month, and again, that's a hybrid style discussion, in person and online. Had great attendance last month down at the Elks Lodge, and looking forward to another good month, another good discussion. Our panel is going to be focused on the boating business. We've got Captain Sean Owen from Conic Sailing, Captain Mike Hall from Annapolis Sailing School, and Captain Boomies, Kate Hollingsworth. You've seen her on YouTube or Facebook more than once. And then our next members tour is out at Thomas Point, Wednesday, June 11th, 9:30 to noon. Cost is $90, and that covers our costs. And if you've got topics that you'd like to discuss for future programs, let somebody in the program committee know, and we'll get it scheduled. So with that, I'd like to introduce Dr. Bill White, who's just synonymous with the sailing community here in Annapolis. Lecturing, a retired physician, and just I don't have enough time to read all the stuff that he's done. Obviously, a ton of sailing experience, and a CAPCA member, a volunteer coach for the Naval Academy, and doing a transatlantic here next month. So with that, I'm going to turn it over to Dr. Bill White.
Thanks, Dave. Let me get my slideshow up and running here. Okay, so I'm Bill White. I am a licensed captain and retired physician, as Dave was so kind to put out. I'm going to get started with the talk, and would ask that you ask questions anytime you want, but I probably won't stop the presentation to answer. We'll get to them at the end. So without further ado, going for medical preparation for captains and charters, how to prepare and how to handle. So this talk is really based around charters and deliveries, bay cruising and offshore sailing. I want to cover what to prepare for, how to evaluate situations that come up, how to manage common problems, when to call for help, and what items that you should have in your kit besides the usual medical things that you get. There's lots of ways that you can be sick at sea. We're not going to cover all of them, but some common things from this list we will go into. It's a little bit beyond the scope of the lecture to go into everything. Your preparation begins before you leave the dock. You need to consider individual medical considerations for your crew members, as well as clients, what to put in your medical kits that may not already be there, maybe some considerations for the medical parts of your ditch kits, and possibly contracting with consultation services so you can get medical assistance live while at sea. Once you're underway, we're going to get into how to manage seasickness, hypothermia, some common injuries, some dangerous injuries, some illnesses, and when to divert or call for help. So who's coming on your boat? You should know your crew. They might have a really interesting sick sense of humor, but they might also be sick. So you need to know what medications they take, what allergies to medications they may have, what medical problems they have had in the past or may actively be being treated for, and what their physical limitations might be. People are often a little reluctant to tell you all this stuff. So short of them actually telling you, at least have them put it down on paper and put it in an envelope so that it's available should you need to find out underway. You can also consider having them sign a HIPAA waiver so that they're okaying that you have this information. This can be contentious at times. It's not common. Most people are really good about it. As far as your clients go, it's important to know about them too, but it's not always easy to do. It can be a sensitive topic. So use some tact and concern for privacy and emphasize that you're doing this for their safety. What about your medical kit? You got to be prepared. Your medical kit should be commensurate with the duration and location of your voyage. If you're going for a weekend cruise, you can get by with a relatively small kit, maybe something about the size of a loaf of bread or two. If you're going transoceanic, you're going to need a far more extensive kit, and you may need to augment that with things such as prescription medications. For a list of what you should carry in your medical kit, you can check out the CCA Fleet Surgeon's memo. If you screenshot or take a photograph of the slide, you can see the link at the bottom of this slide to take a look at that memo. At the very least, your kit should have a basic guide for helping you work through medical problems. You can get 3 of them are listed here. I also listed a couple of very advanced guides. These go into all kinds of stuff, and if you're interested in it, they're worth having. They're designed for ships that are going to be at sea for quite a while and may have some rather dangerous injuries. So ditch kits. Life rafts often have a small medical kit in them. These days, they're trying to pare down on some of this stuff, so there may not be a kit there at all. You should know what's in your life raft kit or what's in your ditch kit. And from a medical perspective, at the very least, bandages, some seasick medications, high-grade zinc oxide-based sunblock. This not only helps with sunblock, but it also helps with saltwater sores, which can be a problem if you're in a wet life raft for a few days. Space blankets, some antibacterial ointment, some hydrocortisone cream, and some pain medications. There's lots of other things that you can bring too. From an individual crew or client perspective, many people take medications, so they need to have these easy to grab if you need to get into a life raft. The best way to do this is to have a stocked 1-week supply of medications in a pill box, so you know what medications they need for every day, and each person should write their name on that pill box so you know who it belongs to. If you have medication that needs to be refrigerated, for instance, insulin, You can bring a Yeti mug or other insulated mug and some chemical ice packs. Throw the insulin in the mug, put the ice pack in there, stick the top on it, and these will keep it cold for a surprisingly long period of time, maybe even a full day. If you have a few ice packs, you can keep that cold long enough to treat this person until relief comes. So you need a medical officer on your boat. That can be captain, crew, if you're lucky enough to have a physician, a nurse practitioner, a PA, an EMT, anybody with some experience, that's great. They're a natural candidate. If you want to get further training, there are 3 options listed here: Wilderness Medical Associates, Medical Officer Limited, and Maritime Medical Guides. These people offer really great courses that can be several days in duration and give you a lot of experience with hands-on methods of dealing with medical problems. Safety at Sea also offers a medical lecture very similar to this, which at least gives you an introduction. Lastly, there are medical consultation services such as Maritime Medical Access through George Washington University Hospital Emergency Department. It's a great service. You have to contract with them before you go. You can't call them up when you're underway and say you need help. They're very reasonably priced. Their price is based on the duration and location of your voyage and how many people are on the boat. I've used them several times. I've never had to call them, but they're very, very great people. I know people who've called them and had a wonderful experience with them. So let's get into a few medical problems. When the weather gets like this, almost anybody gets seasick. You may be one of those rare people that doesn't, but I'm not one of them. So you need to be able to understand how to deal with this and how to prevent it if possible. Dealing with seasickness, it helps if you know or understand the mechanism. So it's basically sensory conflict between what your eyes see and what your inner ear balance mechanism feels. If you're down below in a boat and you have no visualization of a horizon, you're bouncing around all over the place, this is maximum sensory conflict. And eventually it's going to stimulate the vomiting center in your brain and you're going to get sick. It's a little better on deck, but still you're going to get motion sickness. If you're normal, that is. It's worse in a life raft. No ventilation, lots of motion, no horizon. It's an inflatable vomitorium. So recognize the early signs, not only in yourself, but in your crewmates and clients, so that you can do something about it when you first see it develop. They may, for me anyway, the first sign is if I could just stop thinking about seasickness, I wouldn't get seasick. Well, it's not really mental. That's just the first symptom as far as I'm concerned. You can get hyper-awareness of your stomach, this kind of full feeling in your throat, yawning, just not feeling good. It takes a bit of time for that linkage, that sensory conflict to develop, but eventually it's going to lead to nausea and vomiting. So late signs, pallor, kind of a greenish hue. Well, if you're darker skin color, that's a little harder to recognize, although the color still does change. The waves of nausea get stronger, and eventually you get into vomiting, and it can get cyclical. Usually after the first time you vomit, you feel better, and many people will think, oh, I got it out of my system, I'm great. Well, maybe you're going to get lucky, but the chances are you're going to start to feel worse again, and you're going to vomit again, and gradually that distance between the episodes gets shorter, and the period of feeling better between them gets less until it's not there anymore, and you get bad seasickness. And as you all have probably heard, you think you're going to die, and worse seasickness, you wish you would die, and the worst seasickness, you realize you're not going to die, it's just going to keep going on. So your preparation begins prior to departure. Consider medicating yourself up to 6 hours, or the crew, before departure, depending on the medication you're using. Some of them take longer to begin to be effective. Start the trip well rested. Certainly going out and partying the night before does not really promote preventing seasickness. Hangovers really don't help much. As far as eating goes, yeah, you should have eaten, have some food in your stomach. Don't stuff yourself. There's no special diet that will prevent seasickness. but you should consider what you're eating. How is it going to feel coming back up? It may have tasted great going down. The reverse may not be true. So consider avoiding really spicy or acidic foods. Prepare your personal gear before you leave the dock. Get everything stowed. Do your navigation chores before you leave the dock, so you're not doing close focus tasks when you're underway down below. Get the ship stores put away. Have some food and fluids readily available. Get your gear for if you need to put on warmer clothes, easy to reach, so you don't have to go down below and grab this stuff. You could try taking some powdered ginger root. This has been shown in a few studies to help prevent seasickness. Vitamin C, not so much. They've done a number of studies. It does not seem to be effective. Relief bands, there's mixed results on these. Some studies say yes, some no. Personally, I don't really care if it's a placebo as long as it works. So if it works for you, great. After you leave the dock, there's a number of things you can do to help keep from getting seasick. Try to avoid fumes and odors like exhaust fumes, diesel fuel smells. Some people don't like the smell of certain foods, like if you open a can of tuna fish, that tends to set some people off. Avoid close focused tasks. Don't sit there and read a book. Don't try to make log entries. These are going to increase your sensory conflict and make it more likely for you to get sick. Get some good ventilation, look around a lot. If you're taking medication, take it at regular intervals like you're supposed to, but don't take it more often than that. You're just likely to get more side effects, and it's not likely to help you be more resistant to seasickness. Try to get regular rest. Being sleep deprived is not good on top of seasickness. And keep something in your stomach, maybe saltines. That's a age-old trick for a lot of people. And also have something to drink close at hand. Stay warm. You leave the dock, it's a nice day, you don't have a whole lot of clothes on, and as you set off offshore, it starts to get dark, and pretty soon you realize you're not feeling good and you don't have enough clothes on. So then you're going to be seasick and hypothermic. So make sure you have the proper gear readily available. Perhaps one of the good tricks you can do, and most people know this, is if you start to get seasick or you're feeling not great, take the wheel. It's amazing how well this works. I've seen people who are lying on the cabin sole for a couple of days, barely drinking at all, certainly not eating, immobile. Finally convinced them to get up on deck and take the wheel, and within 20 to 30 minutes, they are asking for food and water. Truly amazing. The only problem is there's only one wheel on the boat, so you have to take turns. Short of that, there's a trick that I learned that you can do what's called wave riding, where you stand up, balance yourself over your feet, hold on to something so you're not falling over, bend your knees and kind of ride the boat over the waves while you look at the horizon, keep your body as still as you can doing this. It's almost like driving the boat, and it really does help to reduce seasickness. Late treatment. Well, you're not going to be able to stay up in the cockpit forever. That coveted leeward seat is not really going to work. And if your crew members are the one that's sick, they can't stay there forever either. So the key here is to wait until you've had an episode of vomiting. You're going to have a bit of a refractory period where you won't get seasick for at least a few minutes. Use that to get down below, get your gear off, wedge yourself into a bunk in the floor or whatever, the lowest part of the boat, as furthest aft as you can get, head about 30 degrees erect, close your eyes and try and get some rest. Have some water or other fluids close by that you can take small sips, even if it's just a couple of teaspoons every few minutes. This will help to reduce dehydration, or at least reduce the risk of developing it. Take medications that you don't have to swallow. This could be a patch, injections, or suppositories. These will help to keep you feeling as good as possible. Here's an example of somebody who's wedged themselves into a bunk, head 30 degrees erect. He's got a seasickness bag close by, just in case. The bucket works well too. So what medications can you use? In the US, over-the-counter medications are primarily antihistamines, such as Benadryl, Bonine, and Dramamine. They all make you drowsy. They can all make you have some variation in your mental status. Judgment can be impaired. You can be a little bit spacey. Some more so than others. Bonine, meclizine is a little bit less drowsy. It makes you a little bit less sleepy. Stugeron, which is available outside the US, a lot of people swear by this because it doesn't make them as drowsy and seems to help their seasickness more. The one thing to be careful about Stugeron is, especially in older people at higher dose, it can cause both long and short-term Parkinsonian side effects. So be careful with this. You don't want to get Parkinson's disease just to keep from getting seasick. I still know a lot of people swear by it, and that's great. If it works, you don't have significant side effects, terrific. What about the patch? I personally use the patch. It has side effects that I don't like, but it has the advantage of not having to swallow anything, and you don't have to keep taking more of it. It's just on for about 2 or 3 days. I'll go into the side effects, which are significant, and some concerns that you should have or be aware of if you take this medication. Lastly, anti-dopaminergic medication, such as Phenergan, is prescription, just like scopolamine patches are, but you can get it in pills, suppositories, and injectable forms. It too can make you drowsy, but it's a way to get medication into you or someone else on your boat if you're actively throwing up. And by the way, Zofran, which can dissolve on your tongue, does not work for motion sickness, so don't bother trying to bring that along. So the patch causes a few things of concern. It will dilate your eyes. This means you're at risk for glaucoma. If you have glaucoma, do not use the patch. It's contraindicated. It can cause urinary retention, difficult to urinate. If you're still peeing when you got the patch on, that's not a problem. It may be delayed, but you can get your urine out. If you can't, and it's building up and building up, take that patch off, wipe your skin off with some alcohol. You're going to have to find some other way to keep from getting seasick. Of note, antihistamines can also cause a certain degree of urinary retention, usually not as marked as the patch. Also, when your eyes are dilated, they're going to be much more sensitive to light. You really got to wear good dark glasses, and you're not going to be able to focus close very well. So even if you didn't need glasses before, you may need to wear some cheaters to be able to read when you're using scopolamine. It gives you a dry mouth. No matter how much you drink, your mouth is still going to be dry. I tolerate it because I hate being seasick, and the side effects bother me less than seasickness does. It can cause mental status changes. In the past, it's been associated with some hallucinations, but the delivery system has been improved. This is less common now. Do not try to cut the patch in half to reduce the dose. What that does is violate the delivery system, which is a membrane on the other side of the patch that limits how much of the medication seeps into you. If you cut that wide open, you're giving yourself a higher dose initially, even though you cut it in half. This is an example of promethazine, which is Phenergan, both the pill and the suppository form. I would caution you that if you use the suppository and it hurts, take the foil wrapper off first. Works better that way too. So remember, there is no such thing as a perfect seasickness medication. A perfect medication would have no side effects, works for everybody, and guarantees you'll never get seasick. Nothing does that. What works for one person may not work for another, and all medications have side effects. It's important that you have an idea how medication affects you, not only for yourself, but then you get an idea about what it might be doing to somebody else and recognize it if they're having significant side effects. How do you do this? You can find yourself a day at home when you don't have to drink, drive, or operate machinery and try one of these medications so that you know how it affects you. Better to find out at home than when you're offshore in a big storm trying to deal with a boat and you've got a side effect that's making it difficult for you to function. So that's it for seasickness, but we still have to deal with that hypothermia because you weren't dressed enough while you were getting seasick and you're still up in the cockpit and the weather's gotten worse and you're getting very wet. That's how you get chronic hypothermia. Windy, wet, and cold. You can do this on the bay quite easily by being underdressed. And if you're offshore, that risk is even higher. Hypothermia basically has three basic phases. There's mild, when your core body temperature is between about 90 degrees and 95 degrees Fahrenheit. You are starting to get mentally impaired. You're physically impaired. You can't balance. You don't have the strength anymore. Your coordination's off and you're shivering. This is not the kind of person who can jump around and get warm. They may fall because of lack of coordination. Their strength will be off. They may injure themselves or somebody else. They may even fall overboard. So they've gotten past the point where you can just exercise to get warm. Moderate hypothermia begins to be quite dangerous. That, by medical definition, is when your core body temperature is between about 82 degrees and 90 degrees Fahrenheit. At the start of this, your shivering is maximum. You're trying to get those muscles to generate heat to warm you up. Your mental status is definitely decreased. You're not functioning well. You can make really bizarre decisions like taking your clothes off, even though you're cold. After you get below about 86 degrees Fahrenheit, the shivering stops. This is the precipice. This is a very dangerous thing because now your body no longer has that ability to warm itself up and you're sinking towards that severe hypothermia with a body temperature less than 82 degrees Fahrenheit, markedly diminished vital signs, a slow pulse, decreased respirations, coma, not responsive, cardiac arrest. Moderate and severe hypothermia very likely should be gotten off the boat, if at all possible, to get a higher level of care for resuscitation. So, what do you do? The key here is to prevent this, to recognize when you're getting cold before you get truly hypothermic. And a cold stressed person will be shivering, but their core body temperature is going to be above 95. They're going to be functioning normally, alert, able to care for themselves, and normal coordination, but they're going to feel cold. So what do? Boy Scout rules: reduce heat loss, increase heat production. Get off wet clothes, put on dry ones. If need be, get down out of the elements. Wrap yourself up and get warm. Do an active task to generate some body heat. This is somebody who can protect themselves, who's not uncoordinated. They can jump up and down in the cockpit if need be. Hypothermia, mild. Defense mechanisms like being able to swallow, breathing, not choking on things are intact. Your vital signs are okay. Your body is starting to shut down. The blood supply to the arms and legs is diminished. It may be pale, certainly cool to touch. Or if you're darker skinned, again, it may be that they're not quite the same as pale, but they won't look normal. You're going to have sustained, uncontrollable shivering, but your strength is down, your balance is off, your judgment is impaired. You're still going to be fully conscious. This is the person to get down below, out of exposure, take off wet clothes, put on dry clothes, wrap them up like a burrito in some blankets and a vapor barrier, cap on their head. If need be, stick somebody in there with them. And that person should be dressed in some fleece as well, because the last thing you want to do is curl up next to an ice cube, and somebody who's 90 to 95 degrees Fahrenheit feels like an ice cube. So we've covered most of this on this slide. Just realize that a shivering muscle can produce up to 5 times the heat of a non-shivering muscle. So if they're shivering, wrap them up in blankets so that they can keep all that heat in there to help them warm up. It's not always easy to tell when somebody's shivering, and people don't always want to tell you. They don't want to be a burden, even though the wise thing to do is to prevent yourself becoming a burden by getting warm if you're getting cold. But recognize the other symptoms. Mumbles, grumbles, that means your mind's not really functioning well. You're making poor decisions. You're not speaking normally. You're stumbling, tumbling, you're uncoordinated, decreased strength. So Mumbles, grumbles, stumbles, tumbles, and fumbles. Think about that if you're seeing it. You may not really see somebody shivering if they're dressed up in a lot of gear and you can't see them well. Treatment, first and foremost, prevention. Dress for the occasion, layers, foulies, watch cap, no cotton. Cotton does not hold heat when it's wet, and it takes a long time to dry and uses up a lot of your precious body heat to do it. Use fleece, wool, things that will have some ability to keep you warm even if they're wet. Recognize being cold stressed and intervene early before you become a liability both for yourself and your crewmates. Common sense treatment: if you're cold, get warm. Reduce exposure to the cold. Remove wet clothing, put on dry clothing, wrap up like a burrito. Active rewarming is a contention here. If you're not truly hypothermic, that's fine. But putting somebody in a heating blanket and turning it up, if you had that ability, is not really a good idea for somebody who's truly hypothermic, because you can cause circulation to be reestablished in the extremities too fast. That can cause electrolyte shifts, which can cause heart arrhythmias and cause people to die. You can use some active rewarming by placing hot water bottles, armpits, around the neck, or the groin over the great vessels, which will promote core body warming. You can do this inside of a burrito wrap, and this will help, but you got to take them out when they cool off. There's no point sitting in there with a cold water bottle. Moderate to severe hypothermia, not shivering, vital signs profoundly depressed. These people may respond only to voice. They may not be talking at all, but if you talk to them, they'll begin to respond. Or they may respond only to pain, or they may be completely unresponsive. They're not going to be able to stand up and walk. Behavior may be bizarre if they're conscious. These people need to be evacuated. You need to get them to a higher level of care to make sure that they do okay. That's if possible. If you're offshore, that's not a possible thing to have happen. Do everything you can that we've already discussed. So moving on to sailing-related injuries. Injuries to hands, feet, arms, legs are common on sailboats. They're exposed in a high-threat environment. You can do a couple of things, at least, to help prevent injuries. Wear closed-toed shoes, and wear gloves. These will help to prevent a lot of problems. You can still get bruises, sprains, strains, even concussions, lacerations, contusions, and fractures and dislocations. There's lots of things that can happen. Let's go into a little bit of how to deal with these and how to prevent them. There was a study published in Wilderness and Environmental Medicine in 2010 that looked at about 1,200 injuries that occurred on sailboats. You can get the same things on powerboats, except for not with sail changes. But the key take home here is to realize that the contributing factors to a lot of these injuries were crew coordinated maneuvers in heavy weather. The strains on the gear are higher, so if you have a poor technique, it's more likely to result in an injury. If you're trying to coordinate a crew of 8 or 9 people to do a maneuver, it's more likely that somebody won't get it quite right, and your consequences can be more serious. So make sure that when you're going to do a maneuver, everybody knows what it is. They all know their job. They all know when it's going to happen. And if they don't know their job, have somebody else do it or teach them how to do it. Powerboats don't have a lot different, except you're not dealing with the sails. However, you may have a higher rate of speed when visibility is down. You've all seen powerboats going along at high speed at night. It's a temptation because you can, but if you hit something, you're going to hit it a lot harder. You can get sprains, strains, dislocations, fractures, head injuries, all this stuff on powerboats as well. Other contributing factors you might want to consider, both in yourself and your crew: alcohol and substance use, fatigue, and of course, the weather. Sailing, you need to talk about head injuries from booms. 75% of head injuries on sailboats are caused by flying booms, And boom-related injuries are responsible for 80% of the deaths. So what do? Use a preventer. Preventers prevent head injuries. That prevents accidental jibes, but you still got to think about planned jibes. Make sure everybody knows the maneuver you're going to do. Make sure they're all ready and in place. Don't sneak up on them and do it unexpectedly. Call out when your boom's coming across the boat so that people are aware. If you'll notice this guy on the starboard quarter of this boat, he's standing up head above the level of the boom and he's not looking at it. He has no idea if that's coming towards him or not. He's a setup for getting hit in the back of the head and going overboard. Be careful, be aware. Situational awareness. Most injuries in sailboats occur in the cockpit. It can be quite a busy place. When the weather's heavy, the lines are heavily strained. Proper technique is critical to avoiding injury. You see in the bottom left picture here, somebody using really bad technique as an example, how not to load a winch. You could break a finger, you could get a laceration, you could deglove a finger, you could even amputate a finger doing this kind of thing. Be careful. You'll also notice that everybody's feet that you can see in this picture, they're all wearing closed-toed shoes. That's great. 2 people are not wearing gloves. Even if you're only driving the boat, it's a good idea to wear gloves. Bottom right picture is a painful but not serious injury. Nonetheless, try to avoid it. So sprains, strains, and contusions. These are stable injuries. Stable means bones aren't broken, ligaments are intact, maybe strained, there's no dislocations, everybody is in the right place, but it may not be able to be used normally. It's going to be painful, swollen. You may not be able to do your normal chores on the boat. How do you manage it? Use the PRICE acronym. P, protect the area, splint it if need be. R, rest. That helps reduce pain and inflammation, prevents further injury, so you don't convert a minor injury into a more serious one. Apply ice intermittently, maybe 15 to 20 minutes at a time, every 2 to 4 hours for the first couple of days. If you're going to use ice, and it's a good idea, don't put it directly on your skin. Have something between the ice and your skin so you don't get a thermal injury on top of this. Do not use warm packs for at least the first 72 hours. That will cause increased swelling and delayed healing. C, compression. Use an ACE wrap to wrap the injured or swollen area. This will help to reduce pain and swelling. It will provide a little bit of support, but not a lot. It may be able to make you get up and around a little bit better, but be careful. You're now set up for another fall if you have a sprained ankle and can't get around very well. Elevate the injured area above the level of your heart if you can. This will also help to reduce pain and swelling, decreases that throbbing. How do you splint? SAM splints are a great product. Every medical kit should have 1 or 2. There's a lot of other products out there, same type of thing. Basically, it's a piece of moldable aluminum with a foam coating on it. They're reusable, so you can take it home and practice with it. There's a diagram on the splint that shows you how to use it, and they come in various different sizes, so you can use them for an upper extremity, a lower extremity, or even make a cervical collar out of it if you need to. They're easy to clean. It's closed cell foam, so you can use alcohol to wipe it off if there's blood on it or something. What are unstable injuries? That's when there's loss of continuity to your skeleton. For instance, you have a broken bone that's angulated, or you have a dislocated joint, or there's a ruptured ligament, so this joint is not stable. They're usually easy to recognize, but not always. So you may see an angulation in a long bone, or an arm may be floppy if the humerus is broken. Oftentimes, a joint may be unstable. And oftentimes there's a lot of pain, but not always, because adrenaline can decrease your mind's perception of pain and your body's immediate reaction to it. People call this being in shock, not realizing how badly injured you are. It's not really shock. That's a layman's term. Shock means something else in medicine. But suffice to say, somebody may not be reacting the way you would expect for the injury that they have. That doesn't mean you shouldn't tend to it appropriately. What about wounds? What's the first consideration here? Stop the bleeding, prevent infection, promote healing, and reduce discomfort. So stopping bleeding. Almost all bleeding stops with direct pressure, the vast majority of it. So get some gauze, put on a glove, and slap a hand on top of that, push it down hard, and hold it there. Don't take your hand off every 30 seconds to see if it's still bleeding. That's just going to pump the wound. Apply pressure for 15, maybe 20 minutes, and take it off slowly and see if it stopped. If you notice that your dressing is getting soaked despite your direct pressure, then you've got a bigger problem. You can try using something like Quick Clot. There's other product names out there. This is a great product that really helps stop bleeding, even in serious arterial bleeding. If you need to use it, it's terrific. If you don't have it, or you can't get the bleeding stopped on an extremity, don't do it on the head. You can put on a tourniquet 2 inches wide, about 2 inches above where the wound is. Tighten it down till the bleeding stops. This person isn't going to like you much because they hurt, but you got to do it till the bleeding stops. If somebody has a really large extremity, you might need to put 2 tourniquets on, another one 2 inches above the first one. Once you put a tourniquet on, and you only do this for life-threatening, severe bleeding, once you put that tourniquet on, there is a limited time this person has to get that circulation reestablished, or they're going to lose that extremity. So you put the tourniquet on, write down on the tourniquet or on their skin with a marker what time you put that on. Because when you get to a higher level of care, whoever's seeing them is going to want to know how long that tourniquet has been in place, so they know how much time they have to save that extremity. Oh, and as they told us in medical school, all bleeding stops eventually. So you got a wound, you got the bleeding to stop. You can clean this with just tap water. Now, tap water on a boat is not the same as tap water in your house. So if you're going to use tap water on a boat, you should boil it and let it cool off before you start using it to clean a wound. Better yet, have a gallon of drinking water reserved and write on it for wound irrigation only. So you'll have it basically as part of your medical kit. You don't want to put iodine, alcohol, peroxide, mercurochrome straight into the wound. It kills bacteria, but it also kills the cells that help your wound to heal. You can clean around the wound. And what I would do in the emergency department is take some betadine, which is iodine, put it on a gauze pad, and wipe around the edge of the wound, right at it, 3 times in an ever-increasing circle. And then get another piece of gauze and do the same thing 2 more times. If a little bit of it gets in the wound, it's not the end of the world because you're going to wash it out. When you wash a wound, you want to use high-pressure irrigation. That means having a syringe. If you have a catheter tip that you can use to focus it and push a little bit higher pressure, that's great. If not, using a syringe without the catheter tip works as well. And you can buy irrigation guns if you wish to augment your medical kit. Use 50 cc's of clean water per centimeter of wound to irrigate a clean wound. If you're getting ready to irrigate this wound, get a piece of gauze first, sterile gauze, look in that wound. You've got gloves on, don't forget, wear gloves. Clean out any obvious debris that you can see before you start cleaning it. These people are going to be sensitive, but you've got to do what you've got to do. You may not have been able to numb this wound up. So it's going to hurt a little bit, not as much as you might think. The water's going to sting, but the more you irrigate, the less it stings. If you've got a really dirty wound, use 100 cc's of water per centimeter of wound. After you finish cleaning it, you want to consider wound closure. It's probably going to be bleeding again. You're going to have to put some direct pressure with a piece of sterile gauze because you got this nice and clean now. Don't get it dirty again till the bleeding stops. Suturing is difficult in heavy weather, which is when people are more likely to get injured. Steri-strips work great. Staplers work great. They're easier to use than trying to suture. Even for me, who've done a lot of this, Suturing's not easy in a rocky, rolly boat. Tape, like steri strips, will not stick to wet skin. So you've got to get the bleeding to stop and get the skin dry. You can clean it off with a little bit of alcohol, fan it dry, and then put the tape on. Staplers are easy to get. They're not very expensive. They make good wound closures, and they're easy to use. You might want to practice with one to get the idea of how to use it before you actually have to. You can get a pig's foot, cut the skin on it, and use that to staple it back together, or even with a piece of leather, just cut it and staple it together. If you're going offshore on a long voyage and you think you're going to have to take those staples out before you get to shore, make sure you have a staple remover. You cannot really use the tools you have on board to remove staples. Also, if a wound gets infected, you're going to have to take the staples out anyway. You do not want to keep the infection in there. It'll just make things worse. So what wounds should you not close? A heavily contaminated wound that you can't get clean enough should not be closed. Clean it, but then put some antibacterial cream in there or ointment, some nonstick gauze, some absorbent gauze, and wrap it up. Change the wet dressing once a day and keep it clean. That's your best chance of having a good outcome. If the wound is too old to close, if it's more than 6 to 8 hours old and it's on an extremity, arm, legs, torso, it's too late to close. The scalp and the face have a little better circulation. You can go 10 to 12 hours there. But again, if it's too late, clean it out like you would, but just dress it up and don't close it. Do not close puncture wounds. Puncture wounds are wounds that are considerably deeper than they are long. Clean them as best you can, but do not close them. They're higher risk for infection. Let's move on to head trauma. So how do you know if somebody's had significant head trauma? If they get bumped in the head, relatively small bump, and they have absolutely no symptoms, your risk for a concussion is very low. They've had no loss of consciousness. They're awake and alert, balancing normally, talking normally, acting normally, same ridiculous sense of humor, normal neurologic functions, low risk, not no risk. You can check them again for a couple of days, make sure that no new symptoms are developing. But basically, this is somebody who looks good, continue your voyage, just be careful about what you're having them do. Repetitive concussions are higher risk for more serious injuries. What about a more serious injury? For a concussion, that means a brief loss of consciousness. 1 to 2 minutes is brief in medical terms. If you're watching it, it seems like forever. Altered mental status, they're stunned. Maybe amnesia, they could be perseverating, saying the same thing or asking the same question over and over again. Stable headaches, vomiting once or twice, maybe a bit off balance, maybe the light's bothering their eyes, or light sensitive. These are all possible concussion symptoms. And if they have any of them, not just all of them, but any of them, you ought to consider this to be a concussion. Put them at rest. Try and get them to a higher level of care. Provided they're stable, they can wait a little bit, but you don't want to keep them out there if you don't have to. I wouldn't call for an air evac, but you want to consider heading somewhere where they can get a higher level of care. Don't forget to look for other injuries. In your zeal to evaluate their head injury, you may forget to look at their neck, their back, their arms, or legs to see if anything else was injured. It's not dangerous for them to go to sleep. People think if you get hit in the head, a concussion, don't let them go to sleep. You can let them go to sleep. It's not going to hurt them. The key is to make sure they wake up like they normally would. You don't want somebody to be deteriorating because of it bleeding in their brain and you just think they're asleep. So make sure you check on them every couple hours, wake them up, make sure they wake up like they normally would, then they can go back to sleep. So the more serious problem is when you get a head injury that causes bleeding in your brain and you're getting increased intracranial pressure. There's not much room for blood in there. Your skull is pretty full. So just a little bit of bleeding can cause a big problem. So early signs of increased intracranial pressure. People get alterations in their mental status. They can be irritable, combative, sometimes look fine, sometimes jumping around, screaming, not jumping, but holding their heads. They get poor speech. They get worsening headaches, persistent vomiting, lethargy, and sometimes not very arousable. These are dangerous signs. If you see this, i.e. the concussion symptoms getting worse, not just stable, get them off the boat, get to a higher level of care. If they've had bleeding, you want to get it early before it causes a more serious problem, like in late signs of increased intracranial pressure, where you get obvious neurologic deterioration, seizures, paralysis, posturing. If you may remember when the football player got injured, his hands were doing this kind of bizarre athetoid movements. He had a concussion. Posturing means arms curled up like this, hands turned outwards and wrist flexed. That's decorticate posturing. If your arms are down by your side with the elbows straight and wrists flexed, turned out, that's decerebral posturing. These are very dangerous signs. Vital signs can be off. Slow heart rate, high blood pressure. Your pupils can become unequal. Now, here's another thing. If you're using scopolamine, you get a head injury, take it off. Wipe that stuff off the skin with a piece of alcohol. Because if you don't, that warning sign of unequal pupils will be uninterpretable based on the fact that you have scopolamine on. So you got your head injury off the boat. They're off to the emergency department, somewhere that has neurosurgical capability, and you hope they're going to do well. Burns. I'm not going to spend a lot of time here. The basic issue on burns is to keep them clean and keep them covered. Burns get infected and they hurt. So initially, with first-degree burns, which are now known as partial thickness burns, people would put ice on them, but you got to be careful with this because you can decrease blood supply to the area, which actually can exacerbate the burn. It does feel better, but it's not necessarily the right thing to do. Cool rags will help. But what really helps is getting this covered. Using some ointment like bacitracin or Neosporin ointment, or if you're allergic to that, you can use aloe gel or other burn dressings. There's lots of them available in pharmacies. These really help too. Get it covered and get it wrapped up. That will help to reduce pain. If you use some of the Neosporin ointments, and not the creams, the ointments, you can find ones that have pain reliever in them, and that really helps as well. If there are blisters, do not pop them. That just gives bacteria a way to get in there and cause an infection. They're going to rupture eventually anyway. Don't worry about it. Just get them dressed up in a lot of gauze. So if they do, there's some place for it to go. Third-degree burns, same thing. Keep it clean, keep it covered. Third-degree burns or full-thickness burns are more dangerous, and they need to get to a burn center. What else needs to get to a burn center? What's a dangerous burn? One that is circumferential, goes all the way around an extremity or a digit, a finger. These are dangerous because they can cause obstruction of the blood supply. So if that happens, that's got to get to a higher level of care. If somebody's got a ring on, do whatever you can to get it off, even if you have to find a way to cut it. Full thickness burns, what used to be known as third-degree burns, need to get to a burn center. Large body surface area, whole front of your body, an arm, a leg, whole back, those need to go to a burn center. Airway burns, that means nose and mouth. If you see singed nasal hairs or burns in the mouth, that's dangerous. It can make the airway swell and obstruct. Get them to a burn center. Kind of goes without saying, if you got genital burns, burn center. And chemical burns to the eyes and the throat can be quite dangerous. For the eyes, you're going to need to irrigate. And if it's a basic burn, meaning pH is high, that requires a lot of irrigation. And I mean like 15, 20 minutes of eye irrigation. And you need to be able to test it with pH test strips. It's not easy to do on a boat, but you've got to do it as soon as possible, and they should get to a burn center. Acid burns are a little easier to treat. Again, use eye wash, which can be water. Don't put further chemicals in the eyes to try to counteract a burn. Let's move on to infections. This is an example of what a MRSA infection might look like. The cardinal signs of infection are redness, swelling, pain, and heat. Rubor, tumor, dolor, and calor, as they taught me in medical school. These MRSA infections don't always have this nice white spot on the top to identify them. Often it's just a red, swollen, tender area that's hot to the touch. But the bacteria that are causing that infection are also on your skin. That means you don't want to spread this around, so you've got to keep it clean and covered. Put on gloves, wash your hands first, put on gloves, wash this with soap and water. Make sure you use whatever materials that you're washing with. Take them and put them in a plastic bag so they're contained. After washing it, dress it up with some gauze and wrap it up so it's covered, and this person won't be spreading this around. Take off your gloves, put them in that bag, and wash your hands again. Change the dressing maybe once a day. MRSA infections often cause abscesses. Draining these when you don't know what you're doing can be a problem. Even when you do know what you're doing, it might be an issue. So you can buy yourself a time if you have the appropriate antibiotic by starting it, but abscesses won't be cured by antibiotics. They don't penetrate into the abscess cavity. So warm packs, if you have an antibiotic to buy you some time, do it, and then get somewhere where this guy can get more definitive treatment. How about a spreading infection? The top picture shows lymphangitis. This is when bacteria from a localized infection are starting to spread. They're going up the lymph tract towards the armpit and the core of the body where they can get into your bloodstream, causing sepsis, or in layman's terms, blood poisoning. This can be very dangerous. What do you do if you see this? You certainly need to get the higher level of care as soon as possible. Put warm packs on this to improve blood supply, to fight off infection, and if you have appropriate antibiotic to start for this, use it. If you don't know what the appropriate antibiotic is, consult with your medical consultation services. Sometimes you can even get this through the Coast Guard. Get somebody to give you an idea of what to use. But if you have something like Maritime Medical Access, they will be more than happy to help with this. The bottom picture shows an example of a Vibrio infection. You may have heard of these on the news occasionally. They're not common, but they're very dangerous, and they're caused by saltwater exposure to an open wound. You see these blood-filled blisters that's characteristic of Vibrio. Here's another picture of Vibrio. Very serious infection can go extremely fast and make people very sick, if not kill them, and may lead to amputations. This is an immediate cause for evacuation. It is not responsive to all antibiotics, only certain ones. If you have the appropriate ones, start it. But again, consult before you start. This is cellulitis, soft tissue infection. It can be on the leg or an arm, the torso. It can be almost anywhere. It's characterized by this red, warm, swollen skin and a very defined line that will start to work its way closer to the core of the body. So it spreads. So what do you do? Well, the first thing you do is mark where it is, like they've done here, but write on the skin what time you put that marker on. That'll give you an idea of how fast it's spreading. So you come back 2 hours later and it hasn't moved, that's a good sign. You come back 2 hours later and it's 4 inches further up your leg, that's a really bad sign. It's very dangerous. You can use warm packs. You can use some antibiotics to help you buy you some time, but it's not going to be your ultimate treatment. These people, like those other infections, need to get to a higher level of care as soon as possible. That's pretty much it. I'm going to open up to Q&A here in a moment. But before I do, I want to encourage you, this may be a somewhat contentious issue, but I want to encourage you to think about vaccinations if you're going on long ocean voyages. The last thing you want to do is not prepare your body as well as you're preparing your boat. Consider vaccinations, especially in people over 50, for shingles, for pneumonia. Consider updating your tetanus shot and your your whooping cough, your pertussis vaccination, consider flu and COVID vaccinations. The last thing you want to do when you get on a boat is get sick and pass it to other people on the boat, let alone come down with a serious injury or illness that will cause you to be incapacitated or even die or have permanent damage. That's it. Be happy to take questions. Oh,
All
if
right.
you want to email me, my email address is there. Be happy to answer questions there too, if you want me to.
So starting to get some questions in on the chat. One question came up. You said for a seasickness crew member, get them at the wheel. What,
Yes.
out of curiosity, what is the mechanism for reducing seasickness if someone's at the wheel?
So it is like reducing your sensory conflict, but I can't give a really definitive answer beyond that. I mean, if you're standing at the wheel, you're kind of doing that wave riding like I was talking about, but even sitting, driving the boat, I liken it to being able to see what the boat's doing, you're expecting it, so the conflict isn't as bad, and you feel better. Outside of that, I can't give a definitive answer. I just know that it works better than almost anything.
All right. Thank you. Switching gears a little bit on hypothermia. We've seen advertised, West Marine, REI, the thin foil wraps, the space blankets. Are they effective or are they gimmicky?
So no, they are effective. They help on a couple of bases. They are reflective so that they prevent radiant heat loss. And they also are a vapor barrier, so they prevent evaporative heat loss. It's not the be all and the end all. It helps if you have some kind of fleece or wool underneath it, but they definitely do help.
Okay. And then staying on the subject of hypothermia, uh, do we need to be mindful of different symptoms in kids versus adults? We've all pulled kids out of the ocean down at Ocean City who will swear that they're not cold, and in 10 minutes later, you can't get them warmed up.
Right. Their lips are blue and they're shivering and
I'm not
stuff like
cold.
this. All right. And some of that happens because they go in the water and they've adapted to that to a certain way. Excuse me, I had to chase away a call. But then you get them out and you've got evaporative heat loss on top of the cold water. So especially if the air is dry, they're going to get colder faster when they immediately get out. So yeah, be aware of what might make somebody get colder. So they get out of that water, they say, I'm not cold, dry them off, get them into something warm, especially if the water temperature is really low. I'll give an example. I've spent a fair amount of time in Colorado, and it can be 95 degrees out, and you think, I'm going to go for a swim in this lake, and the lake's kind of cool, but it feels good. And you get out, and it's freezing because that water is evaporating so fast in that really dry air. So beware, evaporative heat loss right after immersion in water can make you get colder pretty quick.
Good point. Thank you. Switching gears back to seasickness, someone was on a naval vessel and they had a midshipman who stopped urinating at all. He was so dehydrated.
Right.
When we've reached that level of dehydration, how long do we have to get him to a hospital?
So you can technically survive without any water for about 3 days. I don't want to push that envelope. There's a few things that you can do. One of them is, it's kind of gross, but you can give somebody an enema and they will absorb water through their colon. It's kind of gross, but as long as you're going to steel yourself that you got to do this, you can get somebody to be hydrated that way. That's also why I said continue, even if you're throwing up, continue to sip. You just threw up, take a sip, take another sip a few minutes later, take a sip a few minutes later. You have to force people to do this because they don't want to, but it will help to keep them hydrated. There is another mechanism called lysis, where instead of starting an IV on somebody, if you have the appropriate water, you can put a needle just under their skin and inject like a liter of water. It causes a big bubble in the soft tissue, but they will absorb it. Now, it's a good idea to get some training on how to do it before you just started, take my word for it. Don't just do it because I mentioned it, but there is a technique if you take the time to learn it.
A couple more. Could you repeat what you said about not applying hydrogen peroxide or alcohol directly to an open wound?
So you don't want to put these things in the wound. You want to wash around the wound. Now, if it's a scratch on the surface of your skin, it's not really going to make much difference. I'm talking about a true laceration that's all the way through the skin. If you put peroxide, iodine, alcohol, these kinds of things directly into the wound, not only does it hurt, it actually kills cells that will help that wound to heal, as well as bacteria. It's better to rinse, to clean that wound, to wash it out with clean water. You can use sterile saline, sterile water, tap water, as long as it's clean tap water, not boat tank water. Those are all fine. But when I wash a wound before I suture, like I said, I'll take some betadine on a piece of gauze. I'll go around the wound before it disappears there, 3 times around it like this in an ever enlarging circle. Get another piece of gauze, get betadine on it, and paint it around the wound. I'm just painting it. I'm not scrubbing it. Do that 3 times. If a little bit of that gets in the wound, I'm not too worried because I'm just about to squirt a whole bunch of water in there and wash it out. In the old days, they used to soak people in dilute betadine. Did their wounds still heal? Yeah, but studies have shown that they don't heal as quickly as if you keep the betadine out of the wound.
Yeah. And I'm asking for a friend. What do you recommend for kidney stones?
A bullet. Kidney stones are really difficult. There is, if you have injectable Toradol, ketorolac, it does provide some immediate relief, but it doesn't last very long. And you cannot keep giving it as often as somebody's going to want it, because you're going to cause stomach ulcers, kidney problems that you can't repetitively dose every 30 minutes to an hour. It's limited to about every 6 hours, and even that, you're pushing the envelope. You can have, you can use ibuprofen or Aleve orally. This may help. Drink lots of fluids. If you have injectable pain medication and want to try use that, you can. But kidney stones are problematic. Once they pass into your bladder, they stop hurting. So passing the kidney stone is painful. Not passing it is worse. If somebody's in extreme pain from a kidney stone, you ought to try and get them off that boat, get them to a hospital. If you're lucky, they'll pass it before the evacuation team gets there.
That's it for questions on the chat board.
Okay. Anybody has anything else, you think of it later, please don't hesitate to email me. I'd be happy to respond as best I can. Also, you talked, one more thing. You talked about kids.
This is Tony Tomasello. May I just make one point?
Sure.
When you were talking about hypothermia, one of the things that I want to add to that is we want to avoid giving people alcohol to warm them up.
Oh, yes, please.
Because it dilates the peripheral blood vessels and then you lose your body heat from the internal organs.
Good point. Yeah, alcohol, brandy with the German Shepherd or the St. Bernard is a fallacy. Alcohol does not warm you up. It makes you think you're getting warm because your peripheral blood vessels dilate and your skin feels warmer. You get this glow, but it actually makes you get colder.
Thank you.
And with kids, kids have much higher body surface to body mass ratio. They will get cold faster. Now, the advantage they have is a higher metabolism, so they can generate a little more heat. Especially small kids are like that. If you notice small kids getting less active or shivering a little bit, get them warm. Don't wait until it becomes extreme. Blue lips, shivering, that's that cold, stressed person. Get them warm before it becomes a problem.
All right. Well, we appreciate that. Thank you, Dr. White. I'm going to take the screen back if I may.
Sure, I'll stop sharing.
Mhm.
There you go.
All right, that should be working now. All right, so I really appreciate it. Thank you, Dr. White. And then again, a reminder, our next discussion, again, it's that hybrid style that we had so much success with a couple months ago, June 23rd, down at the Elks Club. And that is a deeper dive into the boating business. We've got a great panel lined up, and a reminder on our members only tour on June 11th out at Thomas Point.
Well done. Very good. Thank you. Thank you, everybody, for joining us. And I hope that these medical problems never occur on boats that you're on. But when they do, you'll have some ideas of how to handle it. Thank you very much, Dr. White.